The committee will come to order. Without objection, the gentleman from Texas, Dr. Burgess, is authorized to participate in the hearing and ask questions. The Ways and Means Committee is in Denton, Texas for our 7th hearing outside of Washington. I'd like to thank Global Medical Response for hosting us today and giving us the opportunity to see firsthand where you train your pilots, clinicians, and mechanics to respond to emergency situations across the country. One of our priorities is to help every American access quality health care when they need it, where they need it. Unfortunately, for too many Americans, especially those living in rural or underserved communities, when they call 911, help may be too far away to reach them in time. That's because there are no ambulances or emergency healthcare personnel close by to quickly answer the call. Even after help arrives, the trip to the emergency room, if necessary, may be far too long and too expensive. Today, we will hear the stories of Americans who face challenges assessing emergency care. We will also hear from healthcare professionals and first responders who rise to meet those challenges and save lives. Across the country, there is a lack of access to emergency care. 82% of all U.S. counties contain at least one ambulance desert where patients live more than 25 minutes from an ambulance post. In Texas, it's even worse. 95% of the counties in this state have at least one ambulance desert. This problem is amplified in rural areas where driving distances are longer and hospitals are further apart. Nearly 4.5 million Americans in rural counties do not have ready access to acute care, including emergency care. As a result, rural patients can wait up to 30 minutes for EMS after dialing 911 when every second counts. We also know that access to emergency care can also be a challenge for those living in urban communities as well. These health facilities frequently must navigate higher volumes of patients with critical emergencies, often stretching hospital staff and resources to the breaking point. Once in the emergency room, patients face another challenge. Wait times have doubled since 2020. Hospitals have had to cut emergency room staff to make ends meet as insurance companies are slashing reimbursements. It's a nasty consequence from the Biden administration's flawed implementation of a law Congress passed to ban surprise medical bills. Patients in the ER need help quickly. Back in Washington, the Ways and Means Committee has demanded the Biden administration implement the No Surprises Act in accordance with congressional intent and the letter of the law. We will continue our oversight work to shine a light on unfair treatment of patients and ensure Washington bureaucrats follow the laws Congress passes. A good doctor would stop the bleeding, and we need to stop the financial bleeding of emergency rooms in small towns. One solution is a new designation Congress created under the Trump administration that helps struggling rural hospitals keep their 24/7 emergency rooms open and offer needed primary care. The rural emergency hospital designation has the chance to be a winning scenario. Patients in surrounding areas get the emergency care that they need. Low-volume hospitals no longer have the financial pressure to fill beds, and the local economy gets a shot in the arm. Texas has more rural emergency hospitals than any other state. This designation is off to a promising start, but Congress should continue to bolster this option to make it easier for hospital participation and conversion so that small rural hospitals and similar facilities can better provide needed emergency care. We need to embrace creative solutions that come from the American people affected by these issues and can positively disrupt a broken status quo. We know the best solutions are ones where we listen first to the American people. That is why we're here today. There will be clipboards passed out in the audience for everyone to share with us your concerns and ideas. We will enter those into the official hearing record and take those back with us to Washington as we consider how to protect rural communities, our farmers and ranchers and small businesses, to expand access to quality, timely health care. I want to thank everyone for taking the time to come today, and particularly to our witnesses for sharing your stories. I'm pleased to recognize the gentle lady from California, Ms. Chu, for her opening statement.
Thank you, Mr. Chairman, and thank you to the witnesses for being here today. Thanks to Democrats in the House, Senate, and White House, more Americans have access to health care than ever before. During the 2024 open enrollment season, a historic 21.3 million people signed up for care through the Affordable Care Act marketplaces. Millions of Medicare recipients are saving money on prescription drugs, with more to come as Medicare finally negotiates the price of common, costly prescription drugs. We want what's best for America's patients, and that means an affordable, accessible healthcare system. Strengthening access to emergency care is certainly a priority, but so should all types of health care be accessible. In many states in the country, Republicans are the biggest threat to Americans' health and well-being, doubling down on their threats to the Affordable Care Act and working towards a national abortion ban. Their extreme, out-of-touch agenda would only create a sicker, poorer America. We've already seen the deadly consequences of Republicans' war on women. Women are being forced to flee their homes to access care. Doctors are being threatened with prison terms, and hospitals are being ordered to deny care to women with life-threatening complications. Right here in Texas, Republicans cheered on a near-total abortion ban that has put countless lives in danger, like Texas resident Kate Cox, who was denied a medically necessary abortion under draconian state laws and forced to cross state lines to access care. Amanda Zarowski was denied care to address life-threatening pregnancy complications until she went into septic shock. Jennifer Alvarez Estrada Glick died after being deprived of medical information due to doctors' fears of prosecution. Surely these stories prove that Republicans' extremist restrictive abortion bans are a barrier to accessing emergency care for countless women. Not only have Republicans cut women off from accessing abortion care in dozens of states, but their repeated attempts to gut the Affordable Care Act and the premium tax credits that millions of Americans count on would devastate access to care. Over 130 million Americans with pre-existing conditions count on the ACA's consumer protections that prevent insurers from discriminating against them, and millions of working families are only able to afford health care thanks to Democrats' premium tax credits. Republicans' repeal agenda, cheered on by Donald Trump, would put power back in the hands of powerful healthcare industry players while leaving working families to foot the bill. Democrats are ready to go even further toward building the healthcare systems that Americans deserve. In sharp contrast, Republicans are doubling down on dangerous policies that will harm patients' health and well-being. I urge my Republican colleagues to work with Democrats to invest in the American healthcare system and abandon these attempts to limit care that will needlessly drive Americans into these emergency care situations. With that, I yield back.
Thank you, Ms. Chu. I'm pleased to recognize our generous host, Ms. Congresswoman Van Dyne.
Thank you very much, Mr. Chairman. And to all of my colleagues who traveled here today, this region of the great state of Texas is incredibly dynamic. We've seen a massive growth of employers and families moving to North Texas because of the opportunities offered here that can't be found anywhere else. I'm grateful each of you made the time to attend today's field hearing on access to emergency health care. And I'd also like to thank today's host, Global Medical Response, for allowing us to use their phenomenal facilities. And I also want to thank our witnesses for your time and for being here today. Today's hearing is a continuation of the successful hearings and actions this committee has undertaken to highlight the failed implementation of the No Surprises Act. Last August, I was able to gather with healthcare leaders across North Texas, and during those meetings, I heard repeatedly how unelected bureaucrats are failing to comply with the No Surprises Act. And while this is frustrating for everyone involved, it's the patient who's more often than not stuck in the middle and the most to be hurt. Looking around this hangar, it's clear that citizens have access to life-saving care. Congress, the private sector, our healthcare industry, and certainly this administration must do more to empower patients to make informed decisions. Congress took an important first step in addressing this through the No Surprises Act. Unfortunately, the administration is circumventing the intent of the law, which was designed to provide lower costs and more transparency. I am looking forward to a productive discussion about this. And again, thank you very much, Chairman Smith, for bringing the Ways and Means Committee to North Texas. And I want to welcome everyone to our great Lone Star State. And let's make healthcare great again.
Thank you, Ms. Thank you, Ms. Van Dyne. I'm pleased to recognize another Texan, Mr. Arrington.
Well, I'm not just another Texan, Mr. Chairman. I am from the food, fuel, and fiber capital of the world. We call it God's country. Some call it West Texas. But what we do is put food on the plates of our fellow Americans at a price they can afford. We put clothes on their backs. We turn the cranks in the greatest economy in the world, the lifeblood of this great American economy, and we provide affordable energy for the best quality of life and standard of living the world has ever known in the greatest country in human history. Now that's where I hail from. Those are the people I represent. And I've got two colleagues here today on the witness table to bear witness to the fact that without access to critical care in the rural swaths of these great United States, we won't have food security and we won't have energy independence. So our economy suffers, our security suffers, and we put our future in peril. That's what's at stake, and I'm grateful that Mr. Matthews and Mr. Morris especially, two guys from the God-fearing, freedom-loving state of Texas, are here to testify today. Thank you, gentlemen. Chairman, thank you for bringing this field hearing to the great state of Texas.
Thank you, Mr. Arrington. And I'm pleased to recognize the gentleman from Texas that I believe we're in his congressional district, Dr. Burgess.
Yeah, thank you, Mr. Chairman. Thanks for extending the invitation. I'm not actually on the Ways and Means Committee, but I'll reserve the right to object to that. No, this is important, and I want to thank our witnesses for being here today. 4.5 million Americans are residing in counties without access to an acute care hospital, so the disparity in health care across our nation is significant. Texas stands out with areas where there are multiple health care options compared to regions where treatment options are extremely limited. Additionally, we're facing a severe shortage of physicians and emergency health care providers throughout our system, which exacerbates this challenge. Representing North Dallas and having served as a practicing physician for nearly 3 decades prior to my time in Congress, I intimately understand the challenges faced by physicians, from government regulation to inadequate Medicare reimbursements to the issue of burnout. These obstacles underscore the urgent need for bolstering our healthcare workforce. Once again, I want to thank you for having me. Thanks to our witnesses being here. I look forward to the discussion. I yield back.
Thank you, sir. I will now introduce our witnesses. Chloe Burke is an emergency care patient. We have Dr. Edward Rocht, is Chief Medical Officer at Global Medical Response. GMR is our host for today's hearing. Thank you. We have Matt Zavodsky. Okay. How do you say it? Matt. Matt, it's great to have you with us. Is Chief Transformation Officer at MedStar Mobile Healthcare. We have Ted Matthews, is CEO of Anson General Hospital. And we have Robert Morris, is CEO of Complete Care. And then Lauren Miller is an emergency care patient. Thank you all for joining us today. Your written statements will be made part of the hearing record, and you each have 5 minutes to deliver your remarks. Ms. Burke, you may begin.
Today would be silent. Thank you.
Thank you. Dr. Rocket, you are now recognized.
Thank you. Good afternoon, Chairman Smith, members of the committee. A special thanks to the Congresswoman for allowing us to meet here at our hangar with our representatives and being in this beautiful space. Having us serve as host for the venue is very, very much an honor for GMR. My name is Dr. Ed Rocht. I'm an emergency physician. I'm the Chief Medical Officer of Global Medical Response in GMR Medicine. I have the privilege of working with 36,000 other folks who are at work right now, out saving lives throughout the country. And we respond to about 5 million patients a year in all 50 states. As you can see, one of the components of GMR is being able to be ready to take care of patients, as you've just heard Chloe talk about. I appreciate being a part of this discussion in the growing challenges in EMS as we face caring for acutely ill and injured patients in urban, rural, and frontier communities. Emergency medicine combines the science of healthcare with the logistics of getting to that patient's side and getting that patient to the appropriate level of care in the appropriate community in a timely fashion. And I want to give you some good news. The good news is over the past 2 decades, emergency medicine, and congratulations, as you've heard, has done a very good job of refining the science and the delivery of our care to be able to manage patients. We've made tremendous strides in being able to decrease morbidity and mortality from out-of-hospital acute illness and injury. It wasn't that long ago that patients who suffered from a stroke were destined for long-term care or permanent disability. It wasn't that long ago that patients who had a myocardial infarction or a heart attack would have permanent disability, and the myocardium, the heart, wouldn't get back to normal function, so they'd live a disabled life. It wasn't that long ago that patients who were acutely injured, blunt trauma and penetrating trauma outside the hospital, didn't have a chance to survive and live a normal life as they do today. And it wasn't that long ago that individuals like Chloe, individuals that the world saw in Damar Hamlin, who suffered an out-of-hospital cardiac arrest, the team came together, were able to resuscitate them and get them back to a normal life. So the good news is the EMS professionals, the emergency care professionals, have done a very good job of advancing the science and the art of that science to deliver that level of care. Our EMS system, thanks to the committed professionals, to research, to technology, and deployment, has never been this effective at clinically changing life and death situations in the out-of-hospital environment. But remember, these events occur 24 hours a day, 7 days a week, whether it's rain, a beautiful day like today, where it is, how remote it may be from a facility, it may not be near the appropriate facility, these events still occur. So an important part of EMS is being able to anticipate, prepare for, and predict where those emergencies may occur so that we can be in the right spot. That cost of readiness is extraordinary. You have a chance to see that today. To be prepared, the men and women that staff these helicopters, these ambulances, have to be up on the science, the skill, and the art of delivering care to their patients. Our mission in EMS is to manage an acute event whenever and wherever it occurs. Our mission statement at GMR is caring for the world at a moment's notice. I have to tell you, I love that phrase because it says when something happens, we're in there to be able to help the individual get back to normal life. To fulfill that mission, we need that 24/7 readiness and the ability to respond around the clock. The infrastructure and the teamwork is an important part of making sure we are prepared. You've seen the aircraft, you've seen the ambulances. These are mobile ICUs today with the technology to be able to stabilize and treat patients in the out-of-hospital setting. So how we maintain that workforce is an important component during the post-COVID time period. We've struggled with recruiting, we struggled with retention, and many critical access hospitals have closed their doors. So we're trying to maintain that in a difficult time period. We are the front of the front line in medicine. We struggle with all those challenges, and to remain sustainable in the environment, our ambulances and clinicians are that link to life-saving care. We struggle for the response in implementing the principles of the No Surprises Act and being able to create sustainable funding for what we do. One of my colleagues, Flight Nurse Carmen Hicks from Greenville, Texas, is in the room. She responds to these folks, just completed her 500th flight out of a community of 700. She has 200 more to go. She and her colleagues have stories of taking extremely difficult, acutely injured and ill patients and giving them a chance. So we need your help. We need your help to continue to provide care for these life and death circumstances. We need you to help us strengthen the safety net. And all of us in emergency care, all of us in the entire spectrum, thank you for paying attention to this critical issue.
Thank you, sir. Mr. Zavodsky?
Matt's fine.
Matt,
We'll get there.
you're now recognized.
Thank you. Good afternoon. Thank you, Chairman Smith and the House Ways and Means Committee for inviting me to testify at this field hearing, examining the challenges and opportunities surrounding recent events and investments in emergency care and how to strengthen access to emergency care in America. My name is Matt Zavodsky, and I am the Chief Transformation Officer for the Metropolitan Area EMS Authority, which is the public utility model EMS agency for the city of Fort Worth, here in the great state of Texas, and 13 other municipalities that are part of the EMS Authority. We're also known as MedStar Mobile Healthcare. I'm also the South Central Regional Director and past president of the National Association of Emergency Medical Technicians and still work field shifts on an ambulance at MedStar as an EMT. I've been an EMS provider for the past 44 years. It was at a time I could begin serving as an EMT at the age of 7, in case you are doing the math, and learned early in my career that a lot of patients who call 911 for EMS do not need to be treated in an emergency department. But CMS payment policy is such that we are incentivized to force every patient to be transported to the emergency room because that is the only way that we are paid by CMS, is if we transport someone to the hospital. Having the opportunity to advocate for the improvement of EMS models and payments in Texas is an honor. Ambulance services are a vital component of our local and national health care and emergency response systems and serve as lifelines of care for a wide range of individuals, including seniors who rely on Medicare, especially in urban, rural, and in super rural settings. Thankfully, innovative EMS agencies such as MedStar, Global Medical Response, Dallas Fire Department, and others have initiated patient-centric programs designed to prevent 911 calls, and even when 911 is called, appropriately navigate patients to the most appropriate care setting. In 2009, MedStar was one of the nation's first mobile integrated healthcare community paramedic programs in the country. One of our programs is a high utilizer group program. Most of those patients just need hugs. Designed to help frequent 911 callers learn how to better manage their health conditions and connect them to community resources. Since 2013, 22,000 patients have been enrolled in this program, and those patients have reduced their 911 use by 51.2%. They've enhanced their perception of care status by 27%, and reduced their healthcare expenditures relating to ambulance, emergency department, and inpatient care by over $20 million. But yet we have not been paid by Medicare for one of those patients because it's not a covered service. On the 911 side, we have been working with Congress to sponsor legislation to provide EMS the flexibility to navigate patients to the right care at the right time and in the right setting through treatment in place programs. Currently, the EMS economic model incentivizes transport to an ER since treatment in place is not a covered benefit and we don't get reimbursed for that service. A recent study by RAND published in Health Affairs found that 15% of Medicare patients brought by ambulance to the ER could be effectively treated in an alternate setting, and that would save the Medicare program over $550 million annually. Ambulance services across the nation, especially in rural areas, are facing unprecedented challenges, as you heard Dr. Rock talk about. The pandemic further strained our workforce, placed significant new demands on our services, and has generated enormous competition for healthcare personnel. Medicare currently provides temporary 2% urban, 3% rural, and super rural add-on payments for ambulance services. These add-on payments are essential for ensuring access for all patients for vital emergency and non-emergency care, but they still do not bring payment rates up to the level that covers the cost of providing the service. Years of below-cost Medicare reimbursement have hampered efforts by ambulance services to hire, update equipment, and continue to provide life-saving services in their local communities. Ambulance services have closed their doors or been forced to lengthen response times because of the stresses on their systems. These payments, these add-on payments, expire at the end of this year. Ground ambulance services are currently providing their revenue and cost data to CMS, which will help Congress determine how much to reform the Medicare ambulance fee schedule. However, reform is likely several years away, and ground ambulance service organizations cannot wait that long for additional relief. Extending the Medicare add-on payments is essential to ensure access for all patients for vital emergency and non-emergency care. Again, thank you for the opportunity to testify on the challenges and opportunities for EMS to ensure accessibility and quality care to our patients in Texas and the nation. I look forward to continuing to work with you and your committee.
Thank you, sir. Mr. Matthews?
Thank you. Good afternoon. My name is Ted. Excuse me. Good afternoon.
Thank you. I now recognize Ms. Van Dyne.
Thank you very much, Mr. Chairman. I'm going to get us back on topic here. Dr. Rock, can you elaborate on the unique impact of serving the North Texas area with mixtures of urban and rural communities?
So EMS spends a lot of time looking at the configuration of a community, urban, rural, where the healthcare facilities are, where the specific healthcare facilities are. So for example, trauma centers, stroke centers, heart attack centers. One of the unique components of emergency services, and I talked earlier about being prepared and planning, is to bring the physicians, the healthcare systems, the EMS system together to pre-plan how we would approach a system like North Texas. So we depend on call volumes, we depend on injury profile, illness profile, to then strategize on a deployment plan. And that deployment plan is in concert with a hospital, and it's a dynamic plan. So as weather changes, which I think we're all familiar with, that plan can change to get the patient to the right level of care. One of the important components of that process is that it requires that we have knowledge of capabilities of the EMS system. We have knowledge of capabilities and openness, bed availability of the hospitals, and we have a way to get patients to specific areas.
Excellent. Thank you. When drafting the No Surprises Act, the #1 priority was to protect the patient. After that, it was to create a balanced dispute resolution process where providers and payers were on equal footing. What has been GMR's experience during independent dispute resolution?
So we support the No Surprises Act, and we 100% agree that the patient needs to come out of the middle of this. I think, as we've all heard, these are events that are almost always unexpected. They are quite often significant events, and we manage the patient during that time period. The intent of the No Surprises Act was to create an environment to take issues where there was disagreement between the payer and the provider, sort through those issues and reach consensus. Unfortunately, two things cripple us in making that reality come true. One is we can't discuss the medical necessity part of a patient's bill. We can't sit and talk about your question, for example, what was indicated, what was the appropriate level of care, and was this an appropriate decision that was made? The other is that unfortunately, even when we're successful in the IDR process, and again, we support that, even when we're successful, we struggle with collecting from the payers on that particular process, in some cases up to a year. So that creates a significant burden on the EMS system to try and manage in accordance to what we all agreed on was an appropriate way to evaluate those situations.
Excellent. Thank you very much. Mr. Morris, Congress wrote the No Surprises Act very intentional and with specific guidance, yet we have continued to see the administration ignore congressional intent during the implementation. Secretary Becerra is going to be in front of this committee on Wednesday in Ways and Means. If you were in my seat, what questions would you ask him?
Probably the top of the list would be, how are you monitoring, enforcing how qualified payment amounts are determined? Because what we're seeing on our end, what are being used by commercial insurance as qualified payments amounts, we, based on our own actuarial data and Fair Health data, which is a repository of benchmarks of payments, it appears there's a lot of opportunity there for enforcement on working with payers to make sure that they're honoring the way that statute was intended and the way those QPAs are being calculated is appropriate. That would be at the top of my list.
Dr. Roth, what about you?
I think at this point I would ask the question about how we address medical necessity. The main reason that our patients activate, our healthcare systems activate the service, how do we sit down and resolve those based on discussing that patient encounter, the patient's needs, and the reason they entered the system?
Mr. Zavotsky, do you have any? Would you ask a question of Secretary Becerra?
I think I would ask him, what is the right thing for the patient? And in this particular case, certainly in regard to the IDR, it's a flawed process. CMS has even sort of hinted they acknowledge it's a flawed process because it started and stopped and suspended and back on again. So having a close review of the process, making sure that the provider and the payer are on equal footing, which was the original intent. That is clearly not happening, as you're hearing from all the providers here, many of whom are safety net providers that can afford to play the games that are currently being played with the IDR process.
Thank you very much. I yield back.
Thank you. Mr. Arrington?
I want to thank the witnesses for their insights and appreciate your very personal story.
Thank our witnesses for being here today. I am excited about the opportunity to really talk about the need for better infrastructure when it comes to emergency care, but also primary care in rural America. I have the great honor of representing my hometown of Selma, Alabama, and the historic cities of Birmingham and Montgomery, but I also grew up in the Black Belt, a very rural part of my district. And in Alabama, where we have not expanded Medicaid and where we have the lowest reimbursement rate because of the wage index, we have seen that most of our rural hospitals operate in the red. In fact, according to the Alabama Hospital Association, 88% of the rural hospitals in Alabama operate in the red, with 75% of Alabama's rural hospitals also operating in the red. And I have lost rural hospitals in my district because of the inability to sustain a profitable, emergency room. And so one of the ones that I lost literally a month before COVID hit was a hospital in Aliceville. And frankly, the four that were teetering on the brink of being lost was aided greatly by the money that Congress provided for in the CARES Act and the American Rescue Plan. But Aliceville closed. And because of that, we've seen deaths that have occurred in and around that area simply because they haven't had emergency services. And so I want to talk a little bit about the ground ambulance services, because those have been strained as well in Pickens County and other places where closures in the hospitals have occurred. Most days there's only one ambulance covering the entire county of Pickens. That's true of a lot of the counties that I represent. And when that ambulance is tied up, transporting a patient 45 minutes to an hour away, other citizens must wait for a response. Conditions are worse when there is rain and medevac services are not able to transport patients in the air. Pickens County is not the only rural area within my district struggling. That is why I'm proud to co-sponsor with our colleague Brad Winstrup the Protecting Access to Ground Ambulance Medical Services Act that would address inadequate Medicare payments that would help stabilize a lot of those areas. I think that it would be a one way of helping to level the playing field when it comes to providing emergency services. The super rule add-on payment of 22.6% within our bill would help support ground ambulance services in communities like Pickens and all across. I actually wanted to ask my question of you, Dr. Rocket. First of all, thank you for allowing us to be right here in your facility. Can you speak to the dangers of not expanding the add-on payments for ground ambulance, especially for rural, super rural providers?
One of the scariest things in emergency health care, and one of the scariest things that any patient or potential patient has, is what would happen if I had a potentially life-threatening event here or at home or on the way home, and there wasn't a way to get me to the right level of care, and there wasn't a way to immediately stabilize that abnormal physiology when that occurred. Your efforts, and thank you, by the way, for those efforts, your efforts to build the infrastructure to help pay for that cost of readiness. And again, the rural, the frontier area, the good news is there aren't a lot of emergency calls. The bad news is, because there aren't a lot of emergency calls, trying, similar to our hospital colleagues, trying to maintain an infrastructure becomes very difficult.
Yeah. You know, I actually have a personal story, Mr. Chairman. My dad suffered from a stroke in Selma, Alabama. And as you know, strokes are a matter of seconds. Time is of the essence. And the fact of the matter is that our hospital had just gotten a medevac helicopter, which saved my father's life. So I really think that we, as a committee, Mr. Chairman, should work on trying to figure out an add-on payment for ambulance emergency services so that cases like mine are more the norm and not the reverse. I've had patients that have lost their loved ones simply because there wasn't an ambulance service available. Thank you all. I yield back the balance of my time.
Thank you. We're going to pause very briefly to adjust the doors. So I want to take care of our members on the end.
Mr. Chairman, some of our colleagues from the Northeast said the weather's too cold here in Texas. And I said, no, your skin is too thin in the Northeast. So thank you for doing that.
Perfect. Let's stand in recess until the doors are down.
That reminded me I was an invited guest. Matt, your comments about the ambulance service with the being able to have the ability to interact with the population prior to actually transport to a hospital, enormous cost-saving potential there. And unfortunately, Mr. Arrington is no longer here, but on the budget committee, that's one of the things I want us to look at is the enormous cost-saving potential that we have.
Yeah, it absolutely, and it's a pretty easy calculation because we've been able to track how many times Dr. Rock called 911 for some of his issues, and then when he gets enrolled into a community paramedic program from an agency who is familiar with him because they've responded on 911 calls, and is a trusted partner because they're that EMS responder and really can address that. The data that we see in those patients in their decrease in 911 use and decrease in emergency room use is a very simple math calculation and very compelling.
Very compelling. What's the average cost of the ER visit if they get to the hospital without the community participation?
Exactly right. And for Medicare, it's $700–800 for a treat and street ER visit. For a commercial payer, it's usually much higher than that. So the savings across the spectrum of the healthcare system is very dramatic.
Thank you. Thank you, Mr. Chairman. Thanks for letting me be here. I'll yield back.
Thank you, Dr. Burgess. I'd just like to point out for the record.
Let me just thank you all for the tremendous opportunity to come here. I've learned so much today. I just want to thank you, Ms. Burke-Chloe, for reminding us how important the Affordable Care Act has been. Not only could you have stayed on your parents' insurance until you were 26, but you had a pre-existing condition that people would not have, you would have had a $300,000 bill. And so the Affordable Care Act has faced 50 times folks trying to end it, but you are walking, living testimony, sermon in shoes about the importance of it. And you, Mrs. Miller, I'm going to have something to say before my time expires. Dr. Rocket, thank you for hosting us. Dr. Rocket, thank you for closing the door here. I was curious about your testimony and also Mr. Zavadsky. Notice I was not laughing when you said your name. I'm from Wisconsin. I'm used to names like that. You talked about the treatment in place and the inability to get reimbursed. So someone's on a picnic, they get a bee sting, you come along, give them an epinephrine shot, or they have an asthma attack, you give them a breathing treatment. It's all good, you leave, and you can't get paid. Unless you just insist, hold them by gunpoint and say, you better go to the hospital so we can get paid. What? Now, I really do get it that is unfair in terms of not treating you. I'm asking you, Dr. Rocket, what is the argument against that? Is there a fear that, say, for example, this 911 navigator type situation you talked about, Mr. Zavadsky, that people who don't have the proper training might insert their own lack of expertise into a situation and not take someone to the hospital? Is there a liability issue? What's the billing issue that we ought to know about?
So I think one of the things that everyone in EMS would agree on is that we're able to collectively solve issues relating to patient care amongst ourselves. We support, and EMS has supported, Matt's done a tremendous amount of work in looking at mobile integrated healthcare, treat and release, the ability of the EMTs, paramedics, nurses in the field to manage a patient that doesn't necessarily need hospitalization. Unfortunately, because the benefit is a transportation benefit, there's the disincentive to move that patient to a hospital as opposed to solve their problem up front. And the other thing that I would mention, and by the way, putting the doors down is the prevention side of emergency medicine. We have a few ambulances and helicopters, but not enough hospitals to take everyone to. But being able to manage patients up front and prevent their need with chronic illness from having to use the emergency services side is also a very strong argument.
Thank you so much. And I just want to say to you, Mrs.
On services in rural and underserved areas.
Substantially, and the potential is greater moving forward. If we can't sustain those resources, that cost of readiness, because of the struggles with payment after in a post-IDR environment, we're not going to be able to sustain everything that we've been talking about today. One thing that I think is critically important in that process is everybody was excited when that doesn't happen very often, that we finally got an approach to managing the unexpected, the high severity in a way that was fair to the patient, that allowed them to heal. And unfortunately, because of the challenge in collection, we've not seen that come to fruition. The important thing to remember from all of us is on the emergency care side, We don't know if you can pay or not. We don't know if you have insurance or not. We may not even be able to talk to you. But we do the same thing to stabilize your anatomy and physiology and get you to the point where you maximize your chance of survival.
Excellent. Thank you. I yield back.
Thank you. Mr. Byer.
Mr. Chairman, Mr. Chairman, thank you very much for giving and welcoming us to your community. When I go home to Kansas nearly every week to contact with constituents, it's always nice to have the opportunity to take our work outside the D.C. bubble and to hear directly from folks impacted by our policy decisions and how they impact them in their daily lives in their own home communities. And what brings us here to Lone Star State today is a critical issue. It affects Kansans, it affects Texans, it affects Americans all over. And we'd all like to think that we'll escape emergency medicals. They happen to other people. But when the unimaginable happen, knowing we can count on responsive and reliable emergency medical care brings us some comfort. A key means of delivering this care, as we talked about earlier, especially in rural communities, is through air ambulance services. The 4th District of Kansas that I represent includes many rural communities which rely on these emergency air services. A study released last spring found that 77% of urban counties and 84% of rural counties have ambulance deserts, locations that can take more than 25 minutes to be reached by ambulance. And in rural areas, after dialing 911, patients can still wait up to 30 minutes for an ambulance to arrive, or even longer. Given the state of air ambulance service can be the difference between life and death. A 2019 study found that injured patients transported by air ambulance were less likely to die than those taken by ground ambulance. That's why last spring I worked with my Ways and Means colleague, Ms. Delbeni, along with Senators Michael Bennett and Marsha Blackburn, to introduce legislation to improve access to the emergency air medical services that are critical for saving lives, particularly those of Americans that live in rural communities. The Protecting Air Ambulances Services for Americans Act would use data collected from the No Surprises Act to update Medicare reimbursement rates for emergency air services. This common sense bipartisan bill will ensure all Americans have efficient access to hospitals and specialty providers regardless of their location. When seconds matter, air ambulances are proven to be the best way to care for patients in need, as those of you that work here at Global Medical Response know. Dr. Rock, in 2002, CMS established the first air ambulance fee schedule. Can you share what improvements and equipment changes you've had since 2002?
Thanks. I didn't realize the hearing was going to last until tomorrow. Substantial. And I think what you've seen, hopefully today, in terms of the technology, in terms of the skill level of our providers, being able to resuscitate, intervene, decision support tools that identify patients that may be at risk for a myocardial infarction, blood carrying capabilities, the ability to stabilize patients in ways that we never, ever would have imagined before. And I think it raises an important point, which is there are two sides to the air ambulance that are critical for patients' morbidity and mortality. The first is we have to get to them, wherever they are, with the tools and the expertise of our providers to stabilize that illness or injury immediately. Because one of the things, as I talked about in the beginning, we have a logistics problem. Nowhere else in medicine do we have this strange problem of saying you have this injury or this illness, but look how far you are, or look where you are in relation to definitive care. So the technology has evolved. It allows us to stabilize. We can communicate a lot of that technology to healthcare facilities and professionals and maximize our ability to make a difference. It's huge.
Yeah. And what risk do you have of the bases being in danger of closing just from not having reliable reimbursement and fee changes that reimbursement rates that have not changed?
It's very worrisome, and it's worrisome in exactly the environment that you're in and described, which is if we can't sustain the technology, the education, the equipment, if we're unable to do that, we essentially have an aircraft that's not moving patients that frequently which can no longer support the ability to stay in that community. So if you were to ask, I think, our colleagues, whether it's hospital, air ambulance, we are fearful that without the support of that cost of readiness, we will have to move bases, we will have to close bases, and as we've already heard, unfortunately, close hospitals.
Well, thank you. And, 5 minutes just isn't enough time to go through all these questions that I have, and the services that y'all provide for our citizens of our country is so important. So I'll yield back, Mr. Chairman.
Thank you. Mr. Smucker is recognized.
Let me get this.
Thank you, Mr. Chairman. I appreciate the opportunity to be with you here in Denton to see the facilities here. I unfortunately didn't get to hear your testimony. My plane was delayed from Pennsylvania, but so didn't have the benefit of hearing that, and heard didn't get some of the initial questions. So I apologize if my questions may duplicate some of those. But I have no background in healthcare. I've been in Congress now for 8 years, and the state Senate prior to that. Fascinated by the advances that we're seeing in the ability to treat patients for various diseases, in the ability to keep Americans healthier. But one of the most frustrating things is I've learned a lot more about healthcare was seeing the impact of maybe reimbursement systems or regulations that we have in place that I think, and the doctors here know a lot better, but I think not only affect how doctors and hospitals are treating patients, but I think disincentivize advancements and sometimes prevent ways of providing better care. So that frustrates me. I know we have those regulations in place for a reason, but it's one of the things that I've noticed in the years that I've been here. I'm particularly interested, Mr. See if I get is it Zavatsky?
Very good, yes.
Zavatsky,
thank you.
Got it.
Very well done.
I am particularly interested in paramedicine, but because here again, by doing preventative care, by doing care prior to getting to an emergency room, the outcomes are better, and I think costs are better as well. I represent Lancaster and York counties in Pennsylvania, and really fortunate in our area, we have access to great. We have a number of healthcare systems have access, so we don't have the problems with access that some of the other rural areas of Pennsylvania do. But we had a paramedicine program that was established in 2016. It started with 99 patients treated in the first year, and now they serve around 1,000 patients per month. And so it's the program has innovated over time to meet the needs of the community. Now even works with patients that are discharged from behavioral health facilities, with new patients to learn about infant CPR, first aid, lots of different things that they're doing. So I don't know, I probably have some questions, but have you seen the paramedicine program hindered by reimbursement models? Can you talk a little bit more about how that's worked for you and what we could do to ensure that these programs could continue to start and grow in communities?
The economic model for a community paramedic program is fundamentally flawed in that Medicare does not recognize it as a covered benefit. Therefore, Medicaid typically does not as well. Commercial insurers typically do not as well. So many community paramedic programs who started with grants, the Medicare did Healthcare Innovation Award grants, and there were 6 of them that were community paramedicine programs. And then as soon as the grant program ran out, they closed because there was no sustainable funding mechanism for it. So it's those communities that have been able to determine and to prove to innovative payers. In our programs, we've got managed Medicare, managed Medicaid, we've got commercial insurers who are paying for our community paramedic program because they've done the back of the napkin math and said, oh my gosh, the outcome and relates to the financial outcomes. Yes, they care about the clinical outcomes and the patient experience, but their number one metric is how much money is it saving them. We need a federal reimbursement program that can be as nimble as Aetna and Cigna and Molina, and as some states who their Medicaid program is now paying to prevent the 911 call because it makes financial sense.
Sure. Thank you. I have a lot more questions about it. Look forward to continuing the discussion. But thank you so much for the work you do, and thank you all for hosting us here. I yield back, Mr. Chairman. I'll give you a few seconds.
Thank you so much, Mr. Smucker. We're glad you made it. Ms. Miller.
Thank you, and thank all of you for being here today. And I also want to give a very special personal thanks to Lauren Billman, and I don't even know if she's still in the audience or not, but she works with Baylor Scott and White Health, and she taught me how to be a congresswoman. Thank you, Lauren. I think she stayed with me for over 4 years, and I was very wet behind the ears when I came from my House of Delegates over to Congress. I represent rural West Virginia. And when we were flying in here, I'm looking out the window going, wow, I've never seen so much flat land and so many houses and businesses. But I would say a third of our committee represent rural areas, rural states. I know Terry and I, Alabama doesn't resemble West Virginia at all, but our people do and our needs do. So we care a lot about access to care. And one of the major barriers patients face in accessing health care, particularly where I am, is transportation. It takes some people 5 hours to get to the hospital. That's crazy. Have any of you been to West Virginia and seen those roads? And those of you who have flown over understand how they go round and round and round those beautiful mountains. So it's important that we get to our providers. And this is what makes medical emergency services crucial to patients in my home. Dr. Rocht, you've been around rural emergency medical response for over 30 years. Can you speak to some of the unique challenges that your team faces in triaging medical responses in remote areas of the country?
I think my colleagues would agree with me, and we talk about it often, that's often the longest journey you will ever have with a critically ill or injured patient without additional help, where you're maintaining them to definitive care. The challenge of access, land here, turn left at the big rock, go to the pond. Mm-hmm. The patient's physiology and anatomy still going through the same processes. We need to find them and get to them. The ability to have other responders assist us in those environments and help with that. And then the patient destination piece. So based on where you are, what's the most appropriate facility to take that patient to, which often is not the closest facility. It sounds counterintuitive, but those critically ill and injured patients often need to go a little bit further to get the specialized care that will give them the outcome that's most important.
On the other hand, I've even heard from my constituents, the EMTs, if somebody falls out of bed, they call 911 and they have to go and help put Granny back in bed, or somebody that weighs 300 or 400 pounds, because the people who are taking care of them can't do it. So it's unique, but we all understand those things. One model that I really think can help in some of these rural EMS challenges is the treat and place model. The treat and place model allows EMS providers to triage and treat patients when an ambulance does arrive on the scene, or to bring them to the lower acuity facilities outside of hospitals and emergency rooms for treatment. Mr. I'm going to say it, Zavadsky.
I'm going to keep saying
Got it. Matt.
Matt's fine.
I'm married to a Matt. I know. I understand from your testimony that you are a longtime advocate for treat and place. Can you explain why this model of care for the EMS services is so impactful in rural communities?
What Dr. Rocket said was very important, is that in many cases, when a rural hospital is not available, when a critical access hospital is not available in the community, like West Virginia, EMS becomes the default healthcare provider, and they're doing everything. In patients that have to be transported 3, 4, 5 hours away to the next most appropriate clinical care facility, that takes the ambulance out of service. It's very inconvenient for the patient. oftentimes that patient can be very effectively treated in place with perhaps a telemedicine connection that gets a prescription or has some other type of follow-up care. Therefore, the ambulance doesn't have to take the patient 3 or 4 hours away. It becomes more available for that community because now the ambulance can go back in service and the patient gets to stay at home. Maybe that crew comes back and checks on the patient in a couple of hours to make sure they're doing okay. But that it increases resources in the community because EMS stays there. It's more convenient for the patient, and it saves a ton of money in getting that patient not having to go to that high expensive medical care facility. So and West Virginia did this. West Virginia state legislature passed a law that allows EMS to be reimbursed for treatment in place services, and that has revolutionized the protocols and the procedures that can be put in place with those providers in West Virginia, like JanCare and others, to really improve not only the medical care, but the availability of resources in those communities.
I know I'm way out of time, but could you talk about the mountainous terrain exception? You heard of that?
Yeah, because of the geography. Mm-hmm. Yes. So that everything has to be taken into account, even weather. We've talked about, a weather exception, because in Lake Tahoe, during the summer, not as big an issue as it is in the winter.
Right.
So we need to make sure that legislation and reimbursement policy takes into account those nuances that you've heard all of us talk about, because healthcare, and specifically emergency services, very unpredictable and very fragile right now.
I know. Thank you. I yield back.
Thank you. Dr. Murphy?
Thank you, Mr.
Thank you, Ms. Fishbach.
Thank you, Mr. Chair. And Dr. Rock, thank you for hosting us today, and for all of the personnel that were here to give us tours and explain equipment to us. We really appreciate it. As you know, I'm from Minnesota, and I was the one that was really cold. So thank you for closing the door. I think they put me here on the end thinking, oh, the Minnesotan can handle it, but not so much. So I appreciate that. But and I also want to thank, Congresswoman Van Dyne and Dr. Burgess and Congressman Arrington for having us here, and I will tell you, all of them hold a very special place in my heart, and so for various reasons, I serve with all of them on various committees, and I just want to tell you that the Texans are very well represented by them, and so they are treasures. So keep sending them to DC because we love working with them. But just so you know, I represent a very rural district. Most of the members have mentioned those things, and the same kinds of things that Congresswoman Tenney had mentioned about, not being able to get healthcare providers. And I was so glad when telemedicine was finally mentioned, because it's something we're focusing on. And just so you understand, if you look at Minnesota, I'm the western half from Canada. I border Canada, and I'm one county short of Iowa. So I've got all of that. My largest city is 50,000. So when we're talking rural, it's a serious issue. And so, emergency response is huge. I mean, and even just getting basic care, my folks have to travel quite a ways just to get the basic care. And so telemedicine is so important. And, and my hospitals survive as critical access hospitals. That's how they survive, because they're very concerned about the 340B and the beds. And so that's from what I've talked to them about, that's why they haven't switched over. But I am very interested in the community paramedic program, and I know that Mrs. Miller mentioned it, and I believe Mr. Smucker mentioned it, because I believe in Minnesota at one point we did have some pilot programs that the state was covering, because I was in the state legislature before I came to Congress, and so I'm just kind of talking about, I know that improves potential outcomes, and I'd love for you to talk a little bit more about that, because in one of your statements you said sometimes they just need a hug. And I think those folks are the repeat kind of that will call 911 and be, so I'm not even going to try. Matt, would you address that for me?
Sure, and congratulations. Minnesota was one of the first states to authorize and pay for community paramedicine services through Medicaid because of the rural areas in Minnesota. And in many of those communities, the only providers that were able to go see those patients were the specially trained local EMS agencies who had the foresight to, Dr. Wilcox and others who were big drivers in that program, to be able to deliver essentially basic primary care for patients in the rural areas to prevent them from having to call 911, to keep them healthy, educate them about their healthcare programs. So, but the same model or the same principle applies from a rural area to a very urban area like ours. You know, we have 20, 30, 40 patients at a time in our high utilizer group patients, our HUG program, and they run the gamut from behavioral health issues to uncontrolled diabetics to uncontrolled asthmatics, pediatric patients. We just did a program, or starting a program with our children's hospital because they're part of the CHIP program. And they said, you know, even though the state won't reimburse us, meaning the CHIP program, because it's not a covered service, the CHIP program is willing to pay for it because it reduces their cost, and they actually will make out better financially by having fewer patients go to their own hospital and having to pay their hospital for those ER visits. So when we look at those patients, the fixes, if you will, and it's typically a 90-day enrollment. We don't want to adopt those patients. We don't want to make them codependent on us. We want to teach them how to better manage their health care so that, like the patient that would have come here to testify, instead of calling 911 20 times in 30 days, we get her connected to the resources, a new primary care physician who happens to be on the bus line because she doesn't have transportation. So by the community paramedic recognizing that, asking the payer, Medicare, to change the patient's primary care physician to one who's on the bus line so she can actually go see the doctor where she couldn't before, those things are what leads to her not calling 911 in the last 6 months. But it's the EMS agency that can recognize that, because the crew says, well, gosh, this is the 7th time in a month that we've come to your house for a low acuity medical complaint. Let's get you into this program to try and get you to stop calling. But we don't get reimbursed for any of that.
But I also see, and I think we saw so much during COVID with the telemedicine, and you know, one of the things is we talk about broadband, we're looking at making sure that we have that, and like in a rural area available. And I see that community paramedic could be such a partner with telemedicine. And I am out of time, and I appreciate the chairman's indulgence. But thank you all for being here, because it's been a wonderful conversation. So thank you, Mr. Chair. I yield back.
Thank you. Mr. Carey?
I want to thank the chairman. I also want to thank the witnesses. I've heard directly from our first responders. That includes and Matt was one of them, including the firefighters, the emergency medical service personnel, of the lack of reimbursement by Medicare to treatment provided to seniors in place, and the fact that it is harming our seniors' access to emergency care. Our country's emergency medical services are struggling, whether it was due from the pandemic, whether it's been related to just simply finding other jobs. So there are workforce challenges in this arena. Currently, Medicare treats the EMS as a transportation service, which fails to recognize the valuable role EMS providers play in delivering essential health care, while also failing to reimburse them properly for the care that they provide. So today, I'm releasing a discussion draft of legislation that I've been working on with several EMS stakeholders that would require the Center for Medicare and Medicaid Innovation to create a model for test treatment in place policies for seniors on Medicare. The model will also qualify providers to be reimbursed for providing care on site or transporting patients to appropriate destinations instead of solely reimbursing for emergency department visits. So would like to work with my colleagues to further that in a bipartisan way. So, Mr. Zavadinsky, or Matt as we will call him, can you explain the potential Medicare savings for treatment in place?
Yeah, so when during the pandemic, Medicare issued a waiver that allowed EMS to get reimbursed for non-transport, which is very appropriate, and we've encouraged that, and you guys helped us with that. 55,000 patients were not transported to the emergency room under that model. At an average cost to the Medicare program of $700 per ER visit, that means that 55,000 patients did not have that Medicare spend for the ER visit and then whatever happens downstream. So based on the healthcare utilization report data, based on 42 million 911 calls that we respond to of which 40% are Medicare patients.
Right.
If we could reduce the transportation of those patients by appropriately treating them in place, using telemedicine, doing other things, and reduce the transport by 15-20%, which is what studies have shown really don't need to be there, we're talking close to a $1.5 billion a year savings to the Medicare program if they would stop reimbursing us for the mile and reimburse us for the treatment we provide.
So to that end, can you give some examples of what exactly treatment in place is like in the field?
Sure, real quick. So the last one that I did, because I did a lot of the treatment in place when I was working on the ambulance during the ET3 model. Pediatric patient, abdominal pain, went to the ER. The ER took 6 hours. The mother got frustrated, drove her home, called 911, falsely thinking that going by ambulance to the ER would get them a higher priority. That's not how that works. 27% of the patients we bring to the ER go to the waiting room directly. Instead of bringing her to the emergency room, we arranged through a telemedicine visit to have her mom take her to the children's center, to the urgent care center, because the patient told us that she was having abdominal pain for 3 days and she hasn't had a bowel movement for a week and a half. Okay, doesn't take a rocket science to probably figure out what's going on there. Mom texted me an hour and a half later. They were in and out of the urgent care. She was treated for her constipation, felt much better, and she was bringing her back to school. Those are the types of patients we're talking about.
And I think those are the good those are the examples that you shared with me when we met. So real quick, because we only have about 53 seconds, how would the treatment in place be handled under balanced billing?
We'd follow the same rules. So whatever the Gap Back Committee recommends and Congress approves, we would do the exact same thing under the treatment in place program, so that the patients, again, aren't in the middle. We work with the payers, and quite frankly, a lot of the commercial payers, as mentioned earlier, are starting to pay us for that service anyway, because they're more willing to pay for that than they are willing to pay for the ER visit.
And with that, Mr. Chairman, I yield back.
Thank you. I would like to thank our witnesses for appearing before us today. I want to thank my colleagues for making the effort to travel to hear from folks across the country outside of Washington, D.C. And I want to thank Ms. Beth Van Dyne and Dr. Burgess and Mr. Arrington for hosting us in your great state of Texas. And I want to thank Global Medical Response once again for allowing us to have this field hearing here. So we're very grateful. Please be advised that members have 2 weeks to submit written questions to be answered later in writing. Those questions and your answers will be made part of the formal hearing record. And with that, the committee stands adjourned.